dear friends. I am fond of something new in a routine case also, and I get so many rare cases also. So this is a new topic in the knee preservation meeting, proximal fibular osteotomy, a new surgery for pain relief and improvement of the joint function in patient with medial condyle osteoarthritis knee, as described by Jiahu Wang and Jiahu Chun there. We all know Chinese are fond of cheapest things with good, attractive everything. So this is one of the Chinese invention. We all know ONE leading cause of disability due to pain stiffness in elderly all over world, and the available options we know, which are expensive, complex, and some of them need revision frequently. Based on the today's knee preservation principle of HTO, this is the prime choice in young patient. But PFO is an alternative to HTO in the knee in the preservation group I am prescribing. Proximal femoral osteotomy proposed as a new surgical option for pain relief and improvement of the medial joint space and improvement in joint function with osteoarthritis. It's a simple, safe, effective, affordable alternative to HTO. Relief of symptoms of pain occurs in almost all the patients by decreasing varus deformity and reduction in medial joint compression. It delays or replaces the TKA in subpopulation of patients with osteoarthritis of the knee. If you search proximal fibular osteotomy and knee osteoarthritis, you will find so many combinations, papers, and words out of this. The basic principle, fibula supports 1/6 of the body weight, thus PFO redistribute the load on the medial and lateral compartments after proximal fibular osteotomy. This is the radiological picture before and after the surgery. We all know biomechanics of aging and the varus knee. As the age advances, the functional decrease in the neck shaft valgus, causing lateral bowing of the femoral shaft, ultimately leads to mechanical axis medially. And the tibia, after osteoporosis and osteoarthritis, tibial plateau compression leads to progressive slipping of the medial plateau in early osteoarthritis, and we see bowing of the tibia typical in osteoarthritis. Evolution of high fibular osteotomy first described Yao Wang in January 2015. He described 47 patients for medial compartment osteoarthritis, were retrospectively followed up, and he concluded that the alignment of the lower extremity and ratio of the knee joint space improved considerably. PhD in 2014 studied cadaveric knees after fibulectomy and found increased the medial compartment pressure, medial condylar pressure, and increased the lateral compartment pressure. In 2015 published results of retrospective series of PFO performed since 1996, Third Hospital of Bibe in China, and Zhang, the senior surgeon, attributes the idea to one of his students from a rural hospital in China. So this was the idea from the China rural hospital. This is the one article published in the knee surgery and related research. There's so many theories have been described in proximal support of the PFO. The basic principle remains the same as described. Principle of non-uniform settlement or stress imbalance syndrome. The bone density of the fibula is higher than the medial tibial and osteoporosis of the medial tibial condyle leads to settlement of the medial pillar. However, fibula support does not allow the lateral tibial plateau to settle. So this results in varus deformity as we studied. The support of the fibula over the lateral condyle transmit weight, but medial tibial condyle has no such support, which leads to non-uniform settlement, and due to change of slope of the medial tibial plateau, produces transverse shearing force to cause the medial shift of the femoral condyle during the weight bearing. In case of osteoporosis, the subchondral bone of the tibia becomes weak, ultimately results in medial shift of the mechanical axis leading to varus deformity. This is the graphic presentation of the non-uniform settlement. And the proximal fibular osteotomy, it corrects the abnormal load and rebalances the settlement. Too many cortices therapy, the same principle. There are 3 cortices on the lateral side, 1 on the medial side. If you remove 2 cortices, it balances. Concept of competition of the muscles. After proximal femoral osteotomy, the proximal fibular segment becomes free from the constraint from the tibiofibular syndesmosis and distal fibula, leading to relative increase of the range of movement of the proximal tibiofibular joint. The muscles attached to the proximal fibula pull the fibular head distally, and hence the tensile force is transmitted from the posterolateral part of the fibular head to lateral femoral condyle. And the lateral joint space of the knee is therefore narrowed to counteract the varus deformity after weight bearing. It helps in reducing the pressure on the medial compartment of the knee and relieving the medial knee pain. The greater the displacement of the fibular head as it is pulled distally has several advantages in great varus deformity correction, medial compartment decompression, and significant clinical improvement in the pain is relieved. Dynamic fibular distalization therapy, it implies the same thing. Greater the displacement of the fibular head, better the correction of varus deformity, more significant increase in symptoms. The slippage phenomena, this also can be prevented by fibular osteotomy. Hung et al. Reported valgus 5 to 7 degree at 3 months after surgery, and improvement in medial joint space on X-ray after 1 year. Wang et al. Reported 46 patients with PFO, follow-up of 12 months with significant decrease in the visual analog score, improvement in the knee function and the scores, and increase in the medial joint space. These are the predictive factors affecting outcome of the proximal fibular osteotomy, radiological and clinical parameters. We all know the cases included were varus knee up to 5 to 7 degree or 10 to 15 degree up to can be included. Moderate to severe medial compartment OA when conservative treatment is not responded and patient is not opting for the costlier treatment. Above the age of 40 years, radiological reading of 1 or 2 OA changes. These are the excluded. Mostly tricompartmental grade 3 or 4 are excluded. Varus more than 10, obese patient, ligamental instability, KL grades K3 and 4, genu valgus. We all know surgical technique. Even the second year, third year resident can perform this operation. There is no need to have any extra training for this. The PM patient want everything free, and we find out cost benefit ratio. So HTO and PFO is same cost apart from the implant. So PFO in certain cases is beneficial in PMJ cases also. Posterolateral approach, we know intermuscular space, subperiosteal dissection to find a fibula, and 2 centimeter long fibula, 6 to centimeter away from the fibular head was cut off using micro oscillating saw. Now, is the graphic and peroperative pictures of the. This was combined with arthroscopic debridement. If required, soft tissue synovectomy, cartilage surface were declined, loose bodies were removed, meniscus was removed in many of the cases where required. Predis maneuver and subchondral drilling was done in all the cases. Lateral patella reticulum was released, and postoperatively gradual graded functional exercise and immediate weight bearing was started. This was the advantage of this technique. This is the pre-operative and post-operative opening of the space on the medial compartment. Zhou et al. Compared STO with PFO in the management of the knee osteoarthritis, and they preferred PFO to STO because of the lower possibility of complications and early recovery. However, they emphasized the importance of an accurate fibular osteotomy site and protection of the peroneal nerve during the surgery. Their recommended site of PFO was 4 to 7 centimeters away from the fibular head to prevent the nerve injury and to achieve the good pain relief after PFO. Routine international post-operative assessment was done in all the cases by them, and Weight-bearing lower extremity radiograph shows average increase in the post-operative medial joint space, and as well as the correction of alignment was also observed in many cases. And they concluded the present study demonstrates that proximal fibular osteotomy effectively relieves pain and improves joint function in patients with a medial compartment osteoarthritis at a mean of 13.38 months post-operatively. These are the prognostic factors for better outcome. We have learned that PFO is a simple, safe, effective, affordable, cheap, no implants required, simple to perform, no training required, early better rehab, and early weight bearing as compared to ST1 UK. There are improvements in the joint space ratio as well as axial alignment. And conversion to total knee arthroplasty following PFO was observed in 4 cases reported by Young after 1 year follow-up. And Lu reported no conversion to total knee arthroplasty following PFO in their study. The other authors did not mention conversion to total knee arthroplasty. The review literature found that all the 7 studies, included studies on the PFO in this review were published between 2015 to 2018 in the English literature and also in the Chinese authors only. The researchers of the third hospital published a maximum number of 3 papers on PFO. These 7 studies included a number of 468 knees, and the most of these studies were on the lower hierarchy of the evidence, with the 6 studies level 4 and 1 study level 3. The PFO was done in these studies for all the grades of symptomatic OA. In 2 out of 7 studies, including 203 knees, the authors did not document the grade of knee osteoarthritis in their patients undergoing PFO. Whereas in the remaining 265 knees, the KL grade of the OA was grade 1 in 61 cases, grade 2 in 97, grade 3 in 60, and grade 4 in 47 knees. The cumulative mean age included in these studies was 60.8 years. Body mass index was 26.27. Follow-up duration of this patient was from 12 to 49 months, with mean 24 to 48 months. Only 4 out of the 7 studies reported their complication following PFO. Nerve palsy was the most frequent complication reported in 14 cases from 294 knees operated. There were 12 palsy and 2 common perineal palsy. All of these nerve palsies were transient and were recovered in the average time of 11.6 months. And the reported outcome of all the 7 studies saw significant improvement in the post-operative value as compared to pre-operative value of visual analog score and the knee society score. Our study is very small, including 9 cases, 15 months follow-up, PMJ all cases, male, female, 4 to 5, and age range was 49 to 16, with the mean age 55.5. The visual analog score pre-operative from 7.8 was reduced to 2.4 at the end of 6 to 8 months, and axial alignment was also nicely corrected. Medial joint space opening was good at the end of the 4 months, and ODI was from 30 to 10, it was reduced. There were no TKR or any additional surgery needed, and 1 case had peroneal nerve palsy, which recovered in 6 to 8 weeks. Pre-operative MRI was done in all the cases to see the status of the knee joint. There were 6 cases of OA grade 1 or 2, and 3 were 3. Degenerative meniscus tear in 7 cases. ACL interstitial degeneration in 2 cases was found, and Lambert-Eaton sign was positive in all the cases. Arthroscopy was done in all. These are few examples before surgery, and the lateral compartment reduced and the medial compartment opening. And this is another case, 52 years female. Third one, 69 years. And MRI was grade 3 at the age of 69 years. Another case, 62 years male, pre-op, post-op X-rays. These short-term results are encouraging, and whether these outcomes will remain unchanged at a longer follow-up time is unclear. Therefore, a longer follow-up study is warranted. The biomechanics of the pain relief, increase in the medial joint space, and correction of the alignment of the PFO need further study. Absence of control group is another limitation, with inability to exclude placebo effect. To conclude, it is a simple, safe, affordable, less expensive, less invasive technique, less rehabilitation, and effective and faster post-op recovery. Does not require insertion of any implant. But success depends upon the level of osteotomy, right technique, no experience required. Our experience of the study of the HFA is minimal. Suitable. This is suitable in most developing countries that lack financial and medical resources. Better alternative surgical options for osteoarthritis medial compartment knee for patients who cannot undergo TKA because of the comorbidities. PFA is simple, cost effective, with speedy recovery, no training experience required. Correct patient selection is the key to success. Correct level of osteotomy is important. Radiological opening of medial joint space does not always correlate with the clinical improvement. How much time one can save for TKR will decide later on. This patient can still undergo TKA in future if it becomes necessary. Thank you all for patient listening. You are welcome to